Okay, today we're going to be doing oxygenation and perfusion. Um, the objectives for this chapter are to describe the principles of respiratory and cardiovascular anatomy and physiology, describe the function and the role of respiratory and cardiovascular systems in oxygenation, describe age-related differences that influence the care of patients with oxygenation problems, identify factors that affect respiratory and cardiovascular function, perform a cardiopulmonary assessment using the appropriate interview questions and physical assessment skills, develop nursing diagnoses that correctly identify problems that can be treated with independent nursing interventions, describe nursing strategies to promote adequate oxygenation and identify the rationale, and then plan, implement, and evaluate nursing care as it relates to selected nursing diagnoses involving oxygenation problems. So oxygenation to the tissues of the body depends on a few things. One is the integrity of the airway system and its ability to transport that air to and from the lungs. We have to have an alveolar system that's working so that the lungs can oxygenate the blood that's going through the veins and remove carbon dioxide from that blood. Okay, so the blood has to be flowing down to the alveoli where it can do that exchange. Also, a proper or a well-functioning cardiovascular system and a good blood supply that's going to carry the nutrients and waste to and from the cells is also a necessary component of oxygenation. You need to know the basic anatomy and physiology of the respiratory and cardiovascular system. You should have a good understanding of the role of these systems and how they work in regards to oxygenation of the cells or the tissue. And you also want to have a good foundation on how to assess oxygenation in patients and be able to plan, implement interventions to promote optimal oxygenation. Okay, the airway starts at the nose. It ends up at the bronchioles, the terminal bronchioles, and it helps us transport and exchange oxygen and carbon dioxide. It's divided into two parts, the upper and the lower. The upper consists of the nose, the pharynx, the larynx, and the epiglottis, and its job is to warm, filter, and humidify the air we breathe in. The lower airway is used to conduct air, help us clear mucus, and help us produce surfactant, which is essential for the lungs to function correctly. Okay, and those airways are lined with mucus that helps us trap different cells, particles, and infectious debris. The mucus covering also helps protect underlying tissue from irritation and infection. And then we also have these hair-like projections in there called ciliae, which also help trap material, and they help with the mucus to move that debris and stuff towards the upper airway so that we can expel it through coughing. Removal is best achieved when the mucus is watery in consistency, so we are always encouraging our patients to drink plenty of fluids. The lungs themselves are considered the main organs of respiration, and they're located in the thoracic cavity on the right and left sides. Um, the right lung has 3 lobes, the left has 2, and they're composed of elastic tissue that stretches and recoils. You might hear people talk about lung compliance, and this is what we're talking about, lung compliancy. How well do the lungs stretch and recoil? People with COPD, emphysema, they've lost that some of that compliancy, so their lungs don't expand and contract the way that they should. And then we have the pleura. That is that membrane that covers the outside of the lungs. Okay, the visceral pleura covers the lungs themselves, and the parietal pleura covers the thoracic cavity. Now, if you look at this picture, what you can see is that the lungs go from the base at the level of the diaphragm to the apex at the top, just above the first rib. And the heart lies right between the right and left lung. Each lung is divided into several lobes. The right has 3 lobes, the left has 2. So I always try to think of the right, that's my stronger side, so I have more lobes there. I have 3 lobes there and 2 on my left. Then we have the main bronchi that branches to each lung from the trach, and then it subdivides into smaller bronchi going to each lobe, and then again it divides, becoming smaller and smaller as they branch throughout the lungs. The smallest of the branches are the bronchioles, and these end at the terminal bronchioles. Again, the lungs are composed of this elastic tissue that can stretch or recoil. And at the end of the bronchioles, we have these little grape-like clusters called alveoli, which really means small air sacs. And this is where our gas exchange takes place. All right, so it's just a small single layer cell of epithelium, and it has a very thin wall that allows for exchange of gas with the capillaries covering the alveoli. So that exchange is happening right there. Surfactant, this is a phospholipid. It helps reduce surface tension between the moist membranes of the alveoli, and that stops them from collapsing. So when the surfactant production is reduced, then the lungs will become stiff and the alveoli start to collapse. The lungs and the thoracic cavity are lined with the membrane called the pleura. We just talked about this. That visceral pleural will cover the lungs, and then we have a parietal pleura that covers the thoracic cavity. And they are continuous sacs, okay, or membranes that form a closed sac. And then there is pleural space between those 2 layers with fluid in it, and that fluid helps act as a lubricant so things can kind of glide in there, and it helps also hold the lungs in a expanded position. So with that fluid, it allows those lungs to move easily along the chest wall to expand and contract or glide, as I stated earlier. Without that fluid, filling and emptying of the lungs could be very difficult. The pressure in the pleural space or intrapleural pressure is atmospheric or considered a negative pressure, and it's that negative pressure with the pleural fluid that helps the lungs go to an expanded position. So as the gas exchange takes place at those little grape-like sacs, those little alveoli, the cells take in oxygen and they release carbon dioxide. All right, and pulmonary ventilation helps that process occur. Okay, and that's the process of respiration and perfusion. So when we talk about pulmonary ventilation, we're talking simply about movement of air in and out of the lungs. Pulmonary ventilation has 2 phases, inspiration and expiration. Inspiration is when we inhale, and expiration is when we exhale. So during that inspiration phase, it's considered an active phase because it involves movement of the muscles and the thorax, and it's bringing air into the lungs. Expiration is considered the passive phase because it's simply moving air back out of the lungs. During inspiration, a couple of things are going to happen. The diaphragm will contract and start to descend, and that causes the thoracic cavity to lengthen. The external intercostal muscles will contract, and that's going to lift the ribs up and outward and cause the sternum to push forward. This causes the chest to become larger from front to back. And the combination of those things will cause an increased lung volume, and it will cause a decrease in the intrapulmonary pressure. This allows the air from outside of the body, where there's a greater area of pressure, to be drawn into the lungs where there is less pressure. Okay, then the lungs relax or recoil after that part takes place. So the diaphragm will relax, it'll move back up, the ribs will move back down, and the sternum will go back into position. And then there'll be a decrease of volume in the lungs and an increase in the pressure within the lungs. As a result, the air in the lungs moves from that area of greater pressure in the lungs to back outside the body where there's less pressure, and it's expired. Because our cells need oxygen and they don't need carbon dioxide, respiration takes place. So this is where the alveoli exchanges that oxygen that we've brought into our body. It takes that oxygen and it exchanges it for carbon dioxide. So it takes the oxygen, or it does that gas exchange where it takes the oxygen in and it releases the carbon dioxide. And it's the process of pulmonary ventilation, respiration, and perfusion, all three, that does this. So pulmonary ventilation, remember, is going to move that air in and out of the lungs. Then respiration is going to be that actual gas exchange where that air that was actually brought in from outside is now going to be exchanged in the alveoli and the blood in those little capillaries. Remember that were wrapped around those grapes. So, those are that blood supply, the capillaries that are bringing it back and forth to the tissues. And then once that exchange takes place, then perfusion of that oxygenated blood goes back to the body tissues. So it's the process of diffusion that really causes this whole gas exchange process to occur. Pretty amazing, right? So we have this gas, which is first outside the body, right? This oxygen is outside the body, and we have a lower area of pressure inside the lungs at the moment than outside the body. So we take this breath and it pulls the lung, it draws the oxygen into the lungs. And then as that oxygen goes down to the alveoli and to the capillaries, and that exchange takes place, the oxygen goes into the bloodstream and the carbon dioxide leaves the body. Okay, and now we have a area of lower concentration outside the body, and so the area of inside the lungs is now higher. So now it's going to move outside the lungs and back into the air outside the body because of the way diffusion works. And that is that movement of gas from the area of higher pressure or concentration to lower concentration. So what kind of factors influence this process of diffusion? So just so you kind of understand it a little bit better, the oxygen, okay, that is outside the body creates a high pressure, right? Um, so inside the lung is carbon dioxide, and that creates a lower pressure. So when the oxygen, when the alveoli have all this carbon dioxide in them, then it creates this low pressure, and so the oxygen is drawn in, and that gas exchange occurs. So then now we have a higher concentration of um, pressure in the lungs because now all the oxygen is there in the alveoles. So now that we have all the oxygen there in the alveoles, the carbon dioxide is going to leave the body because it's going to go to that area of lower pressure because the higher pressure is now inside the lungs. So hopefully that helps it make a little more sense for you. Now, likewise, we now have this great concentration of oxygen in the alveoli, and we have this unoxygenated blood, okay? And so that unoxygenated blood is going to draw that oxygen with that higher concentration into that blood. And so once it gets into the blood, then it's going to be going out to all the tissues in the body. Um, so again, it's moving from that high area of concentration to that lower area. So the carbon dioxide will diffuse across the capillaries into the alveoli and go out of the body for the same reason, because it's moving towards that area of lower concentration. So diffusion of gases in the lungs can be influenced by a lot of different factors, and that includes changes in the surface area. So if our alveolar were to become thick, okay, or our capillary membranes for some reason weren't as permeable, all right, and it changed the surface area, it could inhibit our ability to diffuse or slow it down or impede it, okay? So, for example, let's say we had part of a lung or all of a lung removed, or we had a disease that destroyed the lung tissue, so we didn't have as much surface available. Okay, that would affect our ability to exchange gas. If our lungs weren't completely expanding or collapsed, or if the alveoli collapsed, okay, also known as atelectasis, that could change the pressure in the lungs and also affect the way that we exchange gas, because gas is exchanged by diffusion, like we just talked about. So, it's that area of greater versus area of less concentration that's causing us to breathe in and out, to breathe that oxygen in and release that carbon dioxide. So if that part isn't working, then it's definitely going to affect the way our lungs function. All right. So if one part of the lung is collapsed, okay, or has atelectasis, it won't be able to fulfill the function of respiration. So conditions that could cause a person to have a atelectasis or a collapsed lung would be an obstruction in the airway by some foreign body, mucus, some sort of constriction in the airway, compression on the lungs from the outside by tumors or by enlarged blood vessels, and sometimes immobility. So a condition that would cause any kind of thickening of the alveoli or the capillary membrane, like pneumonia or pulmonary edema, can affect our ability to diffuse and make it very difficult. Okay, if the partial pressure or the pressure from any gas in a mixture, depending on its concentration, can also affect diffusion. So if our oxygen around us on the outside is reduced, like if we went up into the mountains, or if we were in a place enclosed in a place where there were toxic fumes, okay, and we had less oxygen available, that could cause us an issue with diffusion, or with our ability to do proper gas exchange, okay. When oxygen is given to us, okay, and we're given it by either nasal cannula or a mask or whatever, okay, or if it's increased in the air or the atmosphere, maybe we're coming from the mountains down into a lower atmosphere, then we're going to have greater diffusion across those capillary membranes. So as this oxygenated blood moves throughout the tissues of the body, okay, we call that perfusion again. That blood flowing through the lungs is a factor in the amount of oxygen and other gases that are exchanged. So the amount of blood that is in the lung tissue can depend on whether the person is sitting, standing, or lying. Perfusion is always going to be greater in a dependent area. Lung tissue also can depend on the person's level of activity. So a person who is more active will have an increased need for oxygen by their cells and their tissues, and they'll have an increase in cardiac output and an increased blood return back to the lungs. So perfusion to the body's tissue also can depend on adequate supplies of blood and proper cardiovascular functioning to help carry that oxygenated blood and carbon dioxide to and from the lungs. Alterations in respiratory function can occur. One of them is hypoxia, and that really refers to a problem with ventilation, respiration, or perfusion. And it happens when we don't have enough oxygen available to the cells. Common symptoms are going to be dyspnea or shortness of breath or difficulty breathing, elevations in the blood pressure with a small pulse pressure. Now, your pulse pressure is a difference between your systolic and diastolic, and that's important because it's really representative of your stroke volume. And so if that changes, then it could put increased workload on our heart, and we never want to do that. Okay. Um, so also increased respiratory rate and pulse rate, pallor, cyanosis, anxiety, restlessness, confusion, drowsiness, all these things can occur when someone's hypoxic. Hypoxia can also be caused by someone not breathing deep enough, okay, or not taking enough air into the lungs, also known as hypoventilation, and it can sometimes be a chronic condition. The effects of it are going to be things like altered thought process or confusion, headaches, chest pain, enlarged heart. Remember, I said it puts an increased workload on the heart. Clubbing of the fingers and the toes, anorexia, constipation, decreased urinary output. It can mess with your libido, and it can cause extreme muscle weakness and muscle pain. Vesicular breath sounds are soft, low-pitched, with a low rustling quality during inspiration and even softer during expiration. They're the most commonly auscultated breath sounds and most often heard over the lung surfaces. They have a expiration to expiratory ratio of 3:1. This means that the inspiratory phase is greater than that of the expiratory phase. And I'm going to give you a little listen to what these vesicular lung sounds sound like. Vesicular lung sounds. Next is bronchial breath sounds, and these are tubular, hollow sounds that are heard when you auscultate over those large airways, specifically the second and third intercostal spaces. They're going to be louder and more high-pitched than those vesicular breath sounds. So we're going to listen to those next. Bronchial breath sounds. Bronchial breath sounds. Remember, they're heard over those large pipes. And next, we're going to listen to those bronchiovesicular sounds. These are heard in the posterior chest, between the scapula, and in the center of the chest, of the anterior chest. Okay, they're softer than the bronchial sounds, but they still kind of have a tubular quality, a medium pitch sound during expiration, and again over the upper anterior chest and the intercostal areas. Bronchial vesicular sounds. Okay, some abnormal lung sounds you might hear. One is crackles. These are also called alveolar rels, and they're sounds heard in the lungs that indicate fluid in the small airways. The sound crackles are going to create are fine, short, or high-pitched intermittent crackling sounds. The causes of these crackles can be air passing through fluid, pus, or mucus. Common causes of them are pneumonia, heart disease, cystic fibrosis, COPD, and different types of lung infections, and things like pericarditis. So this is what crackles sounds like. This would be similar to something in a pneumonia. Crackles can also be classified as fine, medium, or coarse. Now, wheezing, it can be continuous, heard on expiration, sometimes on inspiration, and it's air passing through an airway that's constricted by swelling, secretions, or some other sort of blockage like a tumor. It's a high-pitched whistling noise. And again, it can happen if you're breathing in or out. It's usually a sign that something in the airway is starting to narrow or causing a problem with airflow. Okay, so the most common causes of wheezing are asthma and COPD. Okay, so here you go, wheezing. A wheeze can be sibilant or sonorous, and what that simply means is sibilant is musical or squeaking. It's high-pitched, continuous. It's heard through inspiration and expiration, and it's caused by air passing through the narrow airway. A sonorous wheeze is considered rhonchi, and it's coarse. It has a snoring quality. It's low-pitched, continuous sounds. It can be heard during inspiration and expiration. Coughing can clear the sound somewhat, and it's caused by air passing around secretions. So how is the cardiovascular system vital for exchange of gas? Well, that's pumping the blood throughout the body, right? And in that blood are those red blood cells, okay? The majority of oxygen is carried by those red blood cells. the hemoglobin in the red blood cells has a strong affinity for oxygen. So most oxygen in the body is carried by those red blood cells as a part of hemoglobin in the form of something called oxyhemoglobin. And this hemoglobin also carries carbon dioxide easily in the form of carboxyhemoglobin. Once the red blood cells reach the tissue, this internal respiration occurs, which is the exchange of the oxygen and carbon dioxide between the blood that's circulating and the cell's tissue. Okay, so if there's any abnormality in the blood itself, it could affect the body's internal respiration process. So, like if someone's hemorrhaging or losing blood, that can cause a decrease in cardiac output, which would cause a reduction in the amount of blood that's circulating and available to perfuse or deliver oxygen to these tissues. Anemia is a decrease in the amount of red blood cells. So when we have anemia, this results in not enough hemoglobin being available to transport the oxygen. And so we may have an inadequate supply of oxygen out to the tissues of the body. Exercise can help improve the transport of this oxygen to the tissues, and regular exercise can contribute to effective pumping of the heart muscle and improved oxygen transport to the cells. In addition to that, the heart itself is this cone-shaped pump, right, that sits in the middle of the lungs, and it has 4 hollow chambers. The upstairs, which we'll call the atria, and the atria receive the blood from the veins, the superior and inferior vena cava, okay, from the left and right pulmonary veins. And then the lower chambers, or the downstairs of the heart, which is the ventricles, and these actually force the blood out of the heart through the arteries, the left and right pulmonary arteries, and the aorta. Then we have the tricuspid and the mitral valves. These are the one-way valves that help guide and direct that blood flow through the heart. Okay. And then we have our exit valves, which are the pulmonary and the aortic valve, which are located in each of the ventricles. Remember that the blood vessels, they carry the blood from the heart to the cells of the body. Arterioles and arteries carry blood away from the ventricles to the capillaries, and the venules and the veins return the blood from the capillaries to the atrias. So the arterioles and the arteries are carrying that oxygenated blood. The venules and the veins are carrying that deoxygenated blood. The capillaries are responsible for the exchange between the blood and the cell. Okay, so that's where that all takes place, is in the capillaries. As the blood is pumped from the heart out to the body through the contractions, okay, deoxygenated blood is then carried from the right side of the heart to the lungs. It picks up oxygen, it releases carbon dioxide, and then that oxygenated blood is returned back to the left side of the heart. And then it's pumped out to the body, okay, where it can perfuse all the tissues. The quantity of the blood that's pumped out of the left ventricle is called the stroke volume. The cardiac volume is how much of the blood is pumped out each minute. So this should be somewhere between 3.5 and 8 liters per minute. And it's calculated using a specific formula, which is cardiac output equals stroke volume times heart rate. So if the cardiac output of a patient is, the cardiac output of a patient with a stroke volume of 70 mLs and a heart rate of 70 beats per minute would be 4.9 liters per minute. All right, so the cardiac output should increase during physical activity and decrease during sleep. And it can vary depending on the patient's body size and metabolic needs. We talked a little bit about the electrical impulse. We're going to talk a little bit more. The SA node, remember, is in the right atrium, okay, and it receives an electrical impulse. Okay, electrical impulses in the heart are controlled by the sympathetic and parasympathetic nervous system. So it sends, this trigger to the SA node, which initiates that electrical impulse. As that SA node goes down, it will slow down. It allows for the atria to fill up, and then it will speed up and go through that AV node. Okay, and then the atria will contract, and then it's going to speed up. It's going to go down through those bundle branches, left and right. It's going to go through those Purkinje fibers and down on into the ventricles. Okay, where it's going to cause another contraction of the ventricles, and that's going to happen in just a split second, one behind the other. Okay, so it's all in a timing, so each one can fill the right amount and shoot the right amount of blood out to the body. Okay, and then after the ventricles contract, okay, that's considered a complete cardiac cycle, and the heart's going to rest for a minute again, and then it's going to start a whole new cycle. A lot of things can influence the way the heart works. For instance, a person's heart rate. Okay, it can be affected by the sympathetic nervous system. So, sympathetic nervous system can stimulate the SA and AV nodes when someone's activity increases, or when they get scared, or they perceive some sort of real, or even if it's not even real, even if they just think it's a threat. That can increase their heart rate if they get scared or they have some fear or some anxiety. So the same thing with the parasympathetic nervous system. Okay, the parasympathetic nervous system can stimulate the SA and the AV nodes by decreasing through the vagus nerve the heart rate. Okay, and that can also help to maintain the heart rate. And also the medulla has some input on the heart rate also, and that's located in the brain. Other chemicals and hormones in the body can play an effect on this, as well as drugs and other things that we put into the body that may affect our cardiac rate, okay, like caffeine, stuff like that. So other issues that we might have are an alteration in the way the heart works is in the rhythm or the rate. Okay, and this can cause an impairment in oxygenation. This can be caused by a dysrhythmia or an arrhythmia, and that would be a disturbance in the rhythm of the heart. Okay, so they're caused by an abnormal rate of electrical impulse from the SA node, or from, if the impulse originates from some other site other than the SA node. And this can be caused by abnormal conduction of electrical impulses throughout the heart. It also can happen with things like heart disease, hypertension, damage to the heart. Certain drugs can cause this. A decrease in the oxygenation and heart tissues can occur, and it can happen with trauma. With dysrhythmias, we can see disturbances of both the heart rate and the rhythm. It can affect the pumping action of the heart and interfere with circulation. It's definitely going to cause some alteration in our ability to oxygenate. Okay, again, if it's interfering with the circulation, the blood flow, hence oxygenation. So some symptoms, how's the patient going to present? Okay, hypotension, dizziness, palpitations, weakness, fainting. Okay. MI we're going to talk about next, but before we talk about that, we're going to talk a little bit about blood flow to the cardiovascular system itself. So the heart has its own blood supply, all right? It goes to the muscles of the heart, and it provides oxygen and nourishment to those muscles and removes waste product. Those main blood vessels that provide that coronary circulation are the right and left coronary arteries, and those come right off of the aorta. They go all the way around the heart, and they cover all areas of the heart, and they help to fill the blood during relaxation of the heart with blood during relaxation of the ventricles. So the blood returns to the right atrium after it passes through that heart muscle through the cardiac veins. Now, in an MI, we actually have a disruption in the blood supply. That's what's going on. Ischemia means the tissue's dying, and the reason why the tissue's dying is because it's not getting that oxygen supply, hence the blood supply. Okay, and the reason why, number one reason why, is usually coronary artery disease. So those fried, fat, greasy, high cholesterol foods clogging up people's arteries, okay, and the blood flow can't get through, or it can only partially get through, and then certain part of the heart is not getting perfused. And when the tissue doesn't get that oxygen from that blood flow, okay, it starts to scream in pain, and that causes that angina. All right, so it's really dying. The tissue or the cell is actually dying because it's not getting the oxygenation that it needs to support life. Okay, so eventually, when someone gets a full blockage, okay, that part of the artery is going to die, and blood won't be able to flow through there anymore. So that's why we do what we call a cabbage, because we have to actually jump around that spot. So you can't flow through that spot anymore because it's dead, and once it's dead, it's done. Okay, so we would pull a vessel from another part of the body, and we would do a jumper cable, and we would jump around that area. So we would go from a part of the vessel in front of that area that's still good, go around the dead spot, and then hook it to another area that's good. And so the blood would just flow around that dead spot, okay, because it can't flow through it. Why your patient wants to, remain healthy and keep those vessels flowing. Okay, so this MI, okay, is something called an acute coronary syndrome, and it's caused by the death of the heart tissue due to that lack of oxygen. All right, also what we know as a heart attack. Now, the angina, that is an imbalance between the amount of oxygen that the heart needs and what it's actually getting. And that's what's causing the chest pain or discomfort, because it needs more, but it's not getting it. It's really sending, a signal to your body that, hey, something's going on here. I don't know what's happening, but I'm not getting what I need. And you're going to feel it today. Okay. So what can that MI cause for this patient? Well, it can cause a disturbance in the heart rate or the rhythm, or both. It can affect the heart's ability to pump. It can interfere with circulation. Like I said, if it's a blockage, right? An MI is a blockage. So if it's a blockage, that means the circulation isn't going through. All right. And if it doesn't go through to the heart, it could affect other areas of the body that the heart is circulating to. Especially if it starts to affect the way the heart functions, and it is going to affect the way the heart functions in some way or another. So these patients are going to have various symptoms, right, when they have this MI. Some people get the left jaw, the left arm pain. Women, they tend to get more GI symptoms and maybe some back pain, and what we call it's different. Their symptoms don't atypical. Their symptoms aren't like everybody else's, so it's a little bit different. So they might have indigestion, they might have nausea, an upset stomach, they might have some back pain, they might not have the left jaw or the shoulder pain at all. Okay. And then heart failure. Okay, so when the heart failure starts to happen, then that heart stops pumping sufficiently altogether. So like if your ejection fraction should be 60 to 80%, this person's is going to be 40, okay, or 39. or some low ridiculous number, okay, because the heart isn't pumping and it's not efficiently pumping. It's pumping a little bit, but not enough to perfuse, not enough to oxygenate the tissues. And this can be caused by heart conditions, chronic hypertension, coronary artery disease, or some disease of the heart valve. Okay, these patients, depending on whether it's right-sided or left-sided. So left-sided, think lungs. Right-sided, think body. Okay, so right-sided, you're going to have that peripheral edema. Left side, you're going to have that pulmonary edema. Okay, that those that lung issues, the inability to breathe, especially like orthopnea and stuff like that because of this pulmonary edema. So, what are some things, overall that can affect that cardiopulmonary function and oxygenation to the body? So, we first talked about the sympathetic and the parasympathetic nervous system and how they can stimulate different things in the body. Okay, they can increase, the sympathetic will increase and parasympathetic will decrease when necessary, rate of respiration and heart rate. Um, the medullary in the brain. Okay, that is going to send and receive different signals in the body to help us control. So other things, okay, chronic and acute illnesses. These can affect a person's cardiopulmonary status. Somebody with kidney or cardiac disorders, they can have things like fluid volume overload, which affects their tissue perfusion and their respiratory function. All right, it causes shortness of breath. If there's fluid in the lungs or in the alveoli, it's going to make it difficult for gas exchange to occur there. Okay, people also with chronic illnesses that have problems that cause muscle wasting or poor muscle tone. So, like Lou Gehrig's disease, um, anything that would affect the respiratory muscles, Guillain-Barré syndrome. Okay, these kind of disease processes affect the respiratory muscles. They make them weak. All right. What about potassium levels? Okay, potassium also affects the muscle. So if your potassium levels are out of whack, that could affect your respiratory muscles. Other things that could contribute to ventilation and respiration and functioning of the heart could be something like anemia. Okay, because if we're anemic, we're not getting enough oxygen out to those tissues. Now, hemoglobin also brings that carbon dioxide out of the body, okay, and helps disperse it back out and in as needed. So, if our body's not getting rid of enough carbon dioxide, that could also create an issue. Um, and myocardial infarction or a heart attack. Okay, we're going to lose our blood supply with this, or some of our blood supply to the heart muscle. How's that going to affect the patient? And then damage to that muscle itself, that cardiac muscle, can interfere with the heart's ability to effectively contract. And as a result of that, tissue perfusion can be decreased because if we're not getting the blood supply out, it can also impair the gas exchange. All right, other physical changes like kyphosis or scoliosis, this curving of the spine, that can affect the lungs' ability to expand and contract, something that we refer to as compliance. Um, Also, things that can interfere with that compliance are things like emphysema, COPD. Okay, we get this like stiffening of the walls of the lungs. Now, in scoliosis or kyphosis, the problem is the spine is curved, and so it's putting pressure on those lungs, so they really don't have room to expand there. If someone had something like ascites, where they had fluid built up in the lungs, or even when they're pregnant, right? You have that push up of the baby, okay, pushing up on the diaphragm. So if the diaphragm can't fully expand and contract, that's going to affect our ability to ventilate. So all these different things. Another thing is obesity. Okay, when we have this fatty tissue in our body, the body doesn't like it. It doesn't send the same type of tissue perfusion. It's not as the fatty tissue is not as cooperative. It's harder to perfuse in those areas. Um, it makes for miles and miles more of extra tissue that has to be involved here, and the body just doesn't like it. Okay, and then a lot of these patients, they don't participate in exercise, so they really don't get the lungs stimulated enough to fully expand. Those alveoli aren't fully expanding the way they're supposed to because they're not fully stimulated. So that's another risk factor. And now they say that there is a little bit of a correlation between obesity and chronic bronchitis. All right, so that's another issue. So a lot of people who are obese are going to be short of breath. Okay, they don't like to participate in exercise, and part of that might be because of the way they feel when they try to. Maybe they feel like they're not getting enough oxygen. Okay, and so those lungs just aren't getting that workout that they need to get. Other things we have to take into consideration are developmental ages. Okay, an infant is going to have a different sort of breathing pattern than a toddler or an adult, and part of that is because the lungs are still in that developmental stage. So when the baby's born, they have a certain amount of alveoli, and as they grow, those alveoli are going to increase in size and number. But in the beginning, the respiratory rate is going to be a little faster because that's not fully developed. Once they get that adequate oxygenation, then their respiratory rate will start to go down a little bit. Surfactant is something that they need, okay? And if they're born before 34 weeks, most likely they're going to need some sort of synthetic surfactant because they're not going to have it developed yet in the lungs. It usually develops between 34 and 36 weeks. And that surfactant helps reopen up the alveoli when they're collapsed. Medications, we do have to think about medications, okay, because with medications, they can affect the way the heart and lungs function. Especially if a patient is receiving something like central nervous system stimulants like opioids. Okay, these can depress the respiratory system and make it difficult for the patient to breathe. They can actually even lead to respiratory depression or arrest if we overdose the patient or if they were to overdose themselves. Okay, and other medications like beta blockers, things like digoxin and other cardiac glycosides will decrease the heart rate. Beta blockers, those are those drugs that end in LOL, like your metoprolol, labetalol, okay, all your LOL drugs, they can all decrease the heart rate, all right, and play an effect on that as well. So you want to think about this. Other medications have the potential to alter the flow of blood out to the tissues of the body. So, you would want to think about that as well. How about lifestyle? What kind of lifestyle considerations do we have to think about when it comes to our lung and our oxygenation status? Okay, so again, a sedentary lifestyle that does not encourage the expansion of these alveoli. It doesn't exercise them. It doesn't help them. So we want our patients to be ambulatory. We don't want them to be working out. Not they don't have to go to the gym and pump weights. We want them to do like these aerobic type of exercises like walking, swimming, and they should be doing them, 3 to 5 or 3 to 6 times a week. Okay, and that's going to help their respiratory system function a little bit better because it stimulates the alveoli to open up, and it also reduces the risk for cardiac disease. Okay, and it just makes us overall better fit. Also, cultural considerations, okay, because sometimes cultures encourage unhealthy choices, and the reason why they encourage unhealthy choices is because they don't really know. They go by traditional things that have been taught to them their entire life. And, my grandmother did it, my great grandmother did it, and so this is what we were taught to do, and this is what we're going to do. When it comes to food, food can really affect the way the body functions, especially if people's bodies aren't processing it. Like, let's say I have a kidney problem, I'm not processing proteins, or I have diabetes and my body doesn't work the same as everybody else when it comes to eating, carbs and fat and stuff like that. So, but traditionally, this is the kind of foods that my family has cooked, prepared, eaten And these are our comfort foods. So these are the things that, especially when I'm sick, that someone might want to give me because they might want to try to comfort me in some way. So you really have to have a full understanding of your patient's cultural background, okay? And how are you going to promote disease um, prevention in that population, okay? And then, getting your patient to buy in or to be compliant with the goals and the plan of care. So, they have to agree to the plan of care. If they don't agree to the plan of care, they're not going to buy into it. And then cigarette smoking. Okay, this is a major problem for patients. It can help them quickly develop lung disease or slowly over several years. Okay, it also leads to things like heart disease and lung cancer. It's one of the most important risk factors that we could talk about when we talk about COPD. Okay, it's a key risk factor for heart disease. All right, so when we work with patients, we want to try to help them develop habits that will increase their oxygenation, okay, and make them live a more functional lifestyle so that they can engage in their normal activities of daily living. That's the type of health that we want to get our patients back to. So when they come into the hospital, we're always trying to get them back to that previous level of functioning. So what kind of things can we give to them to do? And, a lot of these things are going to be non-invasive, non-prescriptive, and it's things that the patient could do themselves to improve their own health. Environmental considerations. So what kind of work does the patient do, or what kind of work have they traditionally done? Is it feasible that they could change that type of work? It might be the only thing that they're educated to do. And so we have to take all those things into consideration. They might work in the coal mines because maybe that's the only good paying job around where they live at. Or why they have to work in this nuclear power plant. And maybe traditionally this has been something that everyone else in the family has done. So I'm going to do it. So other occupational exposures include asbestos, silica, coal dust, and those can all lead to chronic pulmonary issues. Also exposure to radiation, asbestos, arsenic, that can lead to things like lung cancer. And people also who have some sort of other alteration in respiratory function are those who have difficulty performing self-care in a polluted environment. Okay, so for these patients, you might see someone that's exposed to air pollution, and they might experience something like stinging in their eyes or nasal passages, coughing, choking, headaches, and that could be just basic environmental pollution, okay, or air pollution. There's definitely a high correlation between air pollution and lung cancer and different lung diseases. And then psychologically. Okay, so psychological complications. So people who have anxiety or high stress can experience hyperventilation, and it can go above and beyond what the body's normal requirements are. So when they're hyperventilating, they're putting out all this carbon dioxide, okay, or carbon dioxide. I like to call it carbon dioxide because it reminds me that acids are coming off the body, and if they continue, my patient's going to probably end up in an alkalotic state. All right, and then they're going to have additional complications. Other things that can cause that hyperventilation are generalized anxiety. Okay, that can even lead to bronchospasms and even produce asthma attacks in some patients. So that's some other considerations that you might want to think about. So you'll probably want to take a look at 39.1 in your book, that table, and just become familiar with that. A couple things you want to remember. A baby, their chest is very small. Their airways are definitely shorter than an adult, and they're at a higher risk for aspiration. They have a risk for aspiration, okay? So the respiratory rate is going to be increased, and part of that is because, like we talked about earlier, the alveoli, they don't have as many, and their size is a little bit smaller. So as they start to develop and they start to get more alveoli and they start to fully expand and grow, then that respiratory rate will start to decrease. If the patient is born or the baby is born before 34 weeks, we can give something called surfactant. We give it in a synthetic form, and that can be used to help the baby alveoli re-expand or their lungs re-expand. Okay, and then for babies, sometimes you can hear crackles at the end of a deep respiration, and that's a normal finding. With babies, also, you want to remember that they are at risk for upper respiratory tract infections and asthma as a result of secondhand smoke. So you want to really talk to your parents about smoking around the child, especially in closed areas like a car or inside the house. And then their respiratory activity itself is going to be mostly abdominal. And again, because they have that rapid heart rate, it limits their ability to increase their cardiac output by increasing their cardiac output as in adults. So sometimes when you're not getting that good tissue perfusion or that good gas exchange as an adult, our heart rate as a compensatory measure will increase. So the sympathetic nervous system or the medullary or something will stimulate. Okay, it's going to stimulate the cardiac to increase that heart rate and therefore increase our cardiac output. But babies have a limited ability to do that because their heart rate is already elevated. In a child, okay, so in a child, let's talk about toddlers first, okay, or preschoolers, okay. With them, their eustachian tubes, the bronchi, the bronchioles, they're elongated, they're less angular, okay. So as they start to enter into the daycare or school system, they're going to be exposed to those nice little microorganisms that everyone else is bringing in. So at this age, you want to be teaching about good hygiene and tissue etiquette. So what is that tissue etiquette? Well, we're teaching about sneezing and coughing. Okay, so for one, cough into a tissue or into your sleeve. Now, if you sneeze into the tissue, you want to put it into a plastic bag or into a garbage bag. You don't want other people handling that. Okay, and then washing your hands with soap and water whenever possible. And when not possible, you can use hand sanitizer. Remember, when the hands are soiled, we want to wash them. And then these preschool children, because of this exposure to these other kids, you might see a lot of colds and upper respiratory. So then, as the child, and some even with, with ear infections, okay, bronchitis and pneumonia. As the children start to get a little older, they also become at risk and stay at risk for asthma and secondhand smoke. Okay, as long as the parent smokes, it doesn't really matter what age the kid is, because if the kid is exposed to that smoke, it can potentiate a problem. All right, and then by the end of late childhood and during adulthood, that immune system begins to protect people from most of those type of infections. Now, for the child, as they grow, their blood vessels will get larger, and over time, that blood pressure is going to increase and become more normalized towards what our numbers are when we're in adulthood or adolescence. In the geriatric population, okay, a few things that you have to be aware of. For one, the whole respiratory tract itself, the airways, the tissues, all that stuff, they become less elastic or less compliant, as we say. So they don't have that ability to stretch and contract, okay? Kind of like your underwear. You have underwear, you have them for a really long time. After a while, they start to lose the elasticity. All right, so this is the same issue that we will see in the older adult. They're going to become more bony, so you can see those landmarks on them. The respiratory and abdominal muscles are going to be weaker. Okay, what controls a lot of that is skeletal muscle and other respiratory muscles. So these muscles become weaker. The diaphragm becomes less efficient. The chest can't stretch like it used to. Okay, so that's going to affect their ability to inspirate and expirate. So inspiration is going to see a decline. We'll see a decline in that and in the amount of expiration. The airways tend to collapse more easily, and those things put the patient at higher risk for things like pneumonia and other chest infections. And then the heart, As the heart ages, it usually can maintain the cardiac output as long as there's not additional stressors being placed on it. Okay, when we put additional stressors or we increase the workload and the demands on the heart, then other things can happen to the heart. If we're not engaging in enough physical activity or we're not keeping ourselves up to condition, we also have to think about how is that affecting the rest of the body. Also, we may have decreased elasticity of our blood vessels and stiffening of our heart valves, which can affect the way our heart functions. Again, if the patient has things like high blood pressure, how does that affect them? Well, constant high blood pressure can increase, especially the left side of that heart, okay, the left ventricle, right? Because that's where the blood's coming from there and going up into the aorta and out to the system. So it's going to have an increased pressure there. And so that increased pressure can cause sometimes enlargement of that left ventricle of the heart. So, how's that going to affect the patient? For one, less blood can now go in there. All right. So the heart is going to have to work harder to get the blood out to the body where it's supposed to be perfusing, because the chamber is smaller because the walls of the heart are actually thicker. That's what it means by the heart enlarging. Those walls get thicker, and since there's thicker walls, less blood can sit in that chamber. Okay, so that's going to make the heart work harder. And we don't really ever want to put an increased workload on the heart. Okay, it's a muscle, and increased workloads on it could overall cause it to fail or have other issues. So with these age change, what we're going to have is decreased gas exchange and increased work of breathing, decreased elasticity or elastic recoil of the lungs. Expiration will now require use of those accessory muscles. We don't have the same functional capillaries for that gas exchange at the alveoli level. So the capillaries aren't working as well. We have decreased skeletal muscle, and therefore we have decreased strength in the thorax, and we have a reduction in the patient's vital capacity and in their ability to increase their actual residual volume. So how can we help this patient? So rest periods, okay? Encourage rest periods. Do things with high energy early in the day when they have that extra energy, and then rest throughout the day. And they can also use strategies like pursed lip breathing, incentive spirometers, to try to help control their breathing and their shortness of breath. Stop smoking and don't expose others to secondhand smoke. Do those breathing exercises I just talked about. Think about what kind of pollutants am I exposing myself to, and can I reduce the exposure to those pollutants? What kind of extreme weather conditions do I have to worry about? So, like if I have a history of asthma, I don't want to walk out into the extreme cold because that could precipitate an asthma attack. The same thing if I have COPD and it's a hot, humid day and the air quality is really poor, I might have a really difficult time breathing out there. So those are the things that we have to talk about. Also, avoid opioids and sleeping pills. Why? Because they depress the central nervous system and ultimately could cause the patient to go into either a state of respiratory depression or respiratory arrest. All right. And then how are they going to manage at home? What kind of activities are they able to do? And what type of activities do they maybe need assistance with, or do they need to defer to other people? How can they avoid infection? What type of preventative measures would we use? So, we start with hand washing, and then we could also talk about things like the flu vaccine, the pneumonia vaccine. Pillows as necessary to sleep. So these patients may have orthopnea, which means that when they lay flat, they can't breathe. Okay, so they'll sleep on 2 or 3 pillows to sit themselves up at night so that they're able to sleep. Sometimes they'll sleep in a recliner. All right, so go back and look at that's just some of the things, those age-related changes. Okay, and then also it can affect ventilation, cardiac output, the body's ability to respond to stress. So you want to go to page 1490 and take a good look at that chart. Okay, about how the older adult is affected by those changes in oxygenation. So what are some diagnostic tests that we might use? Well, for one, ABGs. Okay, these are going to measure the pH of our blood and our arterial gases, and it helps evaluate our acid-base status and our oxygenation status. This is important because, if the pH is off, the body's going to have to try to compensate somehow, and if the body starts to compensate, it may increase the patient's respiratory rate. It could increase their rate of metabolism. So things could change within the body. And sometimes when those things change, it can cause other issues in the body. Cardiac biomarkers. Okay. So things like creatinine kinase and troponin. All right, we're looking at these things to see if there was some sort of change. So creatinine kinase is going to tell us anytime there's an injury to a tissue, and that includes the heart muscle. The creatinine kinase is not generally specific to the heart muscle. We do use something called creatinine kinase MKMB, and so sometimes, CKMB, and sometimes that can tell us a little bit more about the actual cardio muscle itself. And then we use troponin, and we also use something called myoglobulin. All right, these help us tell when the cardiac injury occurred and the extent of the damage. Okay, and then we're looking at the patient's CBC. All right, we might do a sputum collection and look at the sputum itself to see if there's anything abnormal in it. And you would want to do this first thing in the morning. That's when we collect that sputum. We might do cardiac stress testing. Okay, so this could be a patient either on a treadmill, or we can give them certain medications, and we're checking the heart's ability to respond to stress. How does it respond in a stressful situation? Does it act the way it should? Does it compensate the way it should? Is the body doing everything that it should? Okay, because that tells us risk factors for our patient, or things that we might need to further evaluate them for. So if a patient doesn't pass a cardiac stress test, we might have to do a cardiac cath or something further invasive to see what's going on. EKGs, okay, those are measuring that electrical activity in the heart. Is that signal being released from the SA node, or is it being generated from somewhere else? Because if it's being generated from somewhere else, then we might have some sort of arrhythmia, some sort of blockage, some sort of other problem. Holter monitors. These patients wear. The nice thing about the Holter monitor is they can wear it for 7 days. They can wear it for a month. Okay, and it's going to show us things that happen over a period of time. So a lot of times it's kind of like your car. You take your car to the mechanic and you say, hey, this happens. And when your car's there at the mechanic, it won't act up the way it does when it's with you or when you're in it. This Holter monitor is recording that continuous cardiac activity. So when the patient has these events that don't necessarily happen when they're in the physician's office, this Holter monitor can record it. And there's actually buttons on there that the patient can push in response to certain things that happen that will kind of give us a clue what happened right before the event or what happened right after the event. And then pulmonary function test, and these are basically measuring the ventilation of the patient. So we look at things like tidal volume, vital capacity, forced vital capacity, the expiratory volume, lung capacity, the residual volume, and the expiratory flow rate. All right, so we'll go into that a little bit more when we start to talk about pulmonary function in depth. So tidal volume capacity, that's the amount of air that we inhale and exhale in each breath. The vital capacity is the maximum amount of air that we exhale after we've taken the maximum amount of inspiration in that we can. The forced vital capacity, this is the maximum amount of air that can be forcefully exhaled after a full inspiration. The forced expiratory volume, that is the amount of air that is exhaled at a specific time interval, like the first, second, and third second after a full inspiration. The total lung capacity, this is the amount of air within the lungs at maximum inspiration. The residual volume, this is the amount of air left in the lung at maximal expiration. And then the peak expiratory flow rate. This is the maximum flow attained during the forced vital capacity. So how do we promote adequate respiratory function? Okay, we teach. We teach about things like pollution in the environment. How can the patient promote optimal functioning? For promoting optimal function, we want to think about healthy lifestyle choices and behaviors that can help prevent or manage these different heart and lung diseases, and also things that can improve oxygenation or overall patient status, vaccinations, preventing respiratory infections, how to live in pollution-free environments, and how to manage that altered oxygenation as a result of their shortness of breath and all that stuff. How are we going to manage that? So we also have to manage things like their anxiety and any actual or potential losses of independence that this might lead to, and also promoting good nutrition. Teaching them about support systems that are out there and understanding their different disease processes. Vaccinations, they could really consider influenza and pneumonia for sure. Pollution-free environments, okay? This is really important for someone that has a heart and lung issue. They can make adjustments to maybe the way they live, or sometimes, just not putting themselves into places where there's extra exposure to industrial or occupational hazards, or, by staying in the home, like when we have these unhealthy breathing conditions with this high humidity and heat, maybe using like HEPA um, filters in humidification systems and stuff like that in their homes to prevent dust and environmental triggers, things along that nature. Help them, reduce their anxiety. So, if we teach them those breathing exercises that can reduce their shortness of breath, then we might be able to reduce some of that anxiety, help them cope with the stress. Okay, that's maybe causing additional respiratory problems because that level of stress is increased. Making sure that they eat healthy, okay, lots of fruits and vegetables, low-fat dairy products, whole grains, a variety of proteins, and then reduced amounts of saturated fats, okay, or things with added sugars or salts. A lot of times, these patients who have difficulty breathing, they might have anorexia or nausea. So we want to make sure that they're getting that adequate nutrition in. So you might think about like 6 small meals over the course of a day instead of those 3 large meals, frequent oral hygiene, and frequent resting before they eat to help improve that intake. If they're COPD, we might want to consider a high protein, high calorie diet, because some of these patients can experience malnutrition. And if they're using supplemental oxygen, we want to maybe discuss with them about wearing that O2 cannula during and after meals, because that eating and digestion require a lot more energy. All right, so they're going to need it. Promoting comfort, so things that we can help to promote comfort with is positioning, fluid intake, humidifying that air, making sure that our patients understand how to use different breathing techniques to decrease their shortness of breath and help them control their breathing, and helping our patient pace their activities throughout the day. Maybe scheduling frequent rest periods to conserve energy, and trying to do those high energy tasks early in the day when they have the most amount of energy. Positioning is most important. Okay, that's a non-invasive way that we can help our patient, and it will help the patient's diaphragm free up and expand the chest. So if they're sitting in a slumped position, okay, we don't want that. We want them to sit up so that they can increase that lung expansion. If they have orthopnea, we want them to, sit up on 2 or 3 pillows so that they can breathe better, or maybe even in that high Fowler's position. And this is going to allow those accessory muscles to be used easier, and it will help promote respiration in the patient. Adequate fluids, okay, because this can help thin secretions. We want to drink anywhere from 1.9 to 2.9 liters a day. So, that's about 2 to 3 quarts, and that will help with the patient, okay? The only time we ever restrict fluids in patients is when it's a risk for them, all right? If it's more risk than harm, more risk for harm than good, then we might do something like that, all right? And so in patients that have an increased temperature, those who breathe through the mouth, or coughing, or those that are losing excessive body fluids, we want to encourage those PO fluids, okay? But if someone had heart failure or low sodium levels, then in that case, we might consider restricting fluids. And that's really the only time, is if it's causing them more harm than good. So there's a lot of techniques about breathing, pursed lip breathing, using the incentive spirometer, diaphragmatic breathing. We can teach our patients how to do this controlled breathing, okay? And this is going to help them. So, with the pursed lip, you'll see that in your book, okay, on page 1504. All right, giving the patient humidified air also, that helps, okay? Um, and that pursed lip breathing or the deep breathing can help them control their breathing. So coughing, that helps clear debris and secretions. So we want to promote coughing. Okay, if the cough is dry and non-productive, if a cough is dry, I'm sorry, it's deemed as non-productive. But if it produces secretions, then it's called a productive cough. All right, and those secretions are expelled by coughing or clearing the throat. Those secretions are referred to as sputum. All right, and they can be excessive sometimes. If they're excessive in the lungs, okay, then it's considered congestion, lung congestion. But if the cough is dry, the patient is said to be congested with a non-productive cough. If the cough produces sputum, then the patient is said to be congested with a productive cough. Sometimes patients can't cough on their own, so you might see machines used. Some of these patients, like Lou Gehrig's disease, okay, they don't have those respiratory muscles anymore, so they might use something called a cough assist machine or a cougholator, okay, and it's going to help that patient. It's going to help stimulate that reflex, because the reflex isn't stimulating on its own. And the respiratory muscles aren't really effective right now because of the lung or the respiratory suppression. We may have to suction the airway, okay? Remember the suctioning rules, and suctioning is usually done as needed, okay? And then we might have to help meet some of the oxygenation needs with different medications. So expectorants, those can help remove some of those secretions from the respiratory tract. Also, sometimes they use cough suppressants. All right, those are probably better off in a state where the patient doesn't actually have secretions, because you wouldn't want to suppress their ability to get rid of those secretions. Lozengers, okay, they can take cough lozengers, and sometimes that just helps an irritated throat. They have something in there called benzocaine, and it just numbs or puts an anesthetic on the throat so that it's not so sensitive. So again, we're promoting deep breathing, all right, and this deep breathing is when the patient takes these series of breaths in um, to overcome something like hypoventilation. Okay, so they'll make each breath deep enough to make the bottom ribs move. So unless they have some kind of condition that prevents normal breathing, they can slowly take these deep ventilations nasally, okay, and then expire through the mouth. So they breathe in through the nose. The nose is going to warm that air up and everything and filter it for them. All right, and then slowly they're going to breathe out through the mouth. And this can be done throughout the day, and they can, continue to practice it. Using that incentive spirometer, all right, that's kind of a visual reinforcement for deep breathing because you have that gauge on there so the patient can see, the ball go up and down and measure their own progress. It helps promote gas exchange, okay, and it also helps clear secretions. It's not usually recommended for prophylactic use in the post-op or pediatric patient. And the patient should be, taught how to use the equipment correctly before they actually start to use it. So that pursed lip breathing, that's really to help our patients that have shortness of breath. It can help with panic, okay? And by exhaling through these pursed lips, they put their lips together, kind of like puckered up like you're going to kiss somebody, okay? And it creates this small opening and allows air movement, okay? And it's effective for prolonging expiration, okay? Because prolonged expiration is thought to decrease that airway and narrow it and cause a collapse in the airway with these patients. All right, so hopefully by doing this pursed lip breathing, it can improve gas exchange and help the patient control the rate and the depth of their breathing. All right, and help reduce their feelings of shortness of breath. It also helps them relax, gain control of the shortness of breath, reduce feelings of panic, and manage their daily activities of living because when they use the pursed lip breathing, they're able to get sometimes more accomplished. So your COPD patients, sometimes they have this rapid, shallow breathing pattern that really just kind of exhausts them. And that's because they're using their upper chest. They've changed from that upper chest breathing to more of a diaphragmatic breathing. And so for these people that have these issues with breathing, there's a few things that we can do. We talked a little bit about it, and that's teaching them how to use breathing exercises so that they can control their breathing, decrease the work of their breathing, and hopefully correct some of their respiratory issues, okay, or deficits. If they have just simply hypoventilation, we can sometimes have them try deep breathing exercises, and the idea is to take a deep breath, okay, deep enough that it moves the patient's bottom ribs. And if they don't have a nasal condition or some other conditions, they could do this, okay? So they would start to take a slow, deep breath through the nose, and then they would let it out, through the mouth. And you want to bring it through the nose. That's going to help warm, filter, and humidify that air, okay? And then hopefully, using these exercises, it helps the patient be able to breathe a little more efficiently, all right? And maybe not have such a low pulse ox. All right. Other things that you can do, and also it might even decrease their anxiety and help them relax more, is incentive spirometry. Okay, so incentive spirometry, we usually use this for patients. Okay, and it's for optimal gas exchange, and it helps to clear secretions. Okay, so that we can expectorate them out. So we want to make sure that the patient understands how to properly use the equipment, and patients like this because they can kind of look at the little ball and gauge their own progress. So pursed lip breathing, this is another technique that we can teach patients, especially those patients that have that shortness of breath or that anxiety. Okay, it can help reduce that panicky feeling and help them control their breathing. So they purse their lips together, kind of like if you're about to kiss somebody and they have this little small hole there, and they use it to, breathe in and out nice and slow in a controlled form of breathing. These patients, they have a problem with their airway collapsing at the end of expiration. So this helps improve that air exchange and decreases that shortness of breath. So it also helps the patient control the rate and the depth of the respirations. Again, it reduces anxiety. Okay, so that's the main reason why we can, teach our patients to do this. And if they can use these controlled and efficient ways of breathing, they can kind of conserve their energy throughout the day. It might help them to do some things that they maybe previously weren't able to do because they were too short of breath. And then, of course, as they got short of breath, along with that came the anxiety, and then they just became overwhelmed and they stop. So, this actually can help promote independence if you think about it. So, almost all these breathing techniques, they require the patient sitting up. All right. So you want them sitting up straight. High Fowlers, that's going to help, for one, expand the lungs. Okay. And that's always an intervention that you can do with your patient that's non-invasive, is to have them set up in High Fowlers position. Okay, diaphragmatic breathing. This is also for some people with COPD. They tend to breathe in a shallow, rapid pattern that tires them out. So by using this diaphragmatic breathing, they can reduce the respiratory rate and increase the amount of ventilation in the alveolar sacs. And sometimes that will help them get rid of some of that air during expiration. Remember, that air they need to get out during expiration has acid in it. Okay. And acids, if we retain acids in the body, it's going to put us in an acidotic state, which could further decrease our respiratory rate because acid or an acidotic state will weaken the muscles. And so when your muscles will just get weaker and weaker, all right, and then pretty soon the patient will just start to become very sleepy, and the level of consciousness will start to change, and your patient's status is going to deteriorate. Okay, so this diaphragmatic breathing, okay, um, they're using more of the diaphragm to breathe with instead of the upper chest muscles. All right, some other ways that we're promoting comfort is through positioning. You have to think about, what positioning is best for your patient. And generally, we're talking about sitting the patient upright in that high Fowlers to expand those lungs, a nursing intervention that you can do on your own and a safe one. And it's one you can do while someone is getting oxygen or other things to assist with breathing if it's needed. Okay, when someone slumps over, that puts pressure down on the abdomen, and it can cause that abdomen to push up on the diaphragm, okay, and interfere with the body's ability to fully expand and contract the lungs. Other things with positioning are sometimes for patients that are acutely ill, especially those with ARDS. There is some research that states that when we put the patient in the prone position on a regular basis, it helps promote oxygenation to the dependent sections of the lungs. So they're going to become better ventilated and perfused. All right. So if the patient's on their back or, in a certain position all day, then, this could help to make sure that you get circulation throughout the entire lung sections, like each section all together. All right. What else do you see with positioning? So sometimes you'll see those patients in that tripod positioning, right, where they're leaning forward on their elbows, and that positioning is being used because they can't breathe. So it's helping them to feel like they can breathe better. Fluids. You want to encourage fluids with these patients, anywhere between 2 and 3 liters a day. These fluids can help to move secretions along and keep everything lubricated. Um, They're good for patients that have elevated body temperatures, people that are coughing, people that have lost excessive body fluids. So the people that we would be concerned about with fluids and, with fluids and mobility, these are things that you usually don't ever restrict unless it's going to cause more harm than good for the patient. Okay, so if you're talking about, a cardiac patient and heart failure, or someone who has, hyponatremia, or someone that has kidney failure, then you might want to consider restricting fluids because it certainly could cause them more problems than good. Humidified air. So when the person is going through the process of inspiration, that air coming in from outside can remove that moisture that would normally be inside the respiratory tract. All right, that moisture is in the respiratory tract because it helps protect against irritation and infection. Sometimes certain environments will give us a drying effect, okay, and it will irritate. So if we have low humidity in the air, we may have to use a humidifier or a vaporizer. All right. And sometimes you want to consider also a HEPA filter because that can move environmental toxins from the air. And also the thing with the humidifiers is, one, you have to be cautious with them around children because they put out hot steam. And two, make sure you keep them clean. All right, they can grow bacteria in them, so you really have to be careful, especially the ones that have like those filters and stuff, that they're maintained properly and according to manufacturer's instructions. Chest PT. So, chest PT helps promote drainage. It should be done, early in the day or at routine times, and you want to do it before meals. And you can lay the patient on their side and use gravity to help promote. Okay, and basically, there's a couple ways you can do it. So they have like little cups that you can buy, and you put the cups on, people's back, and you kind of tap it, right? And this vibration or this tapping causes the secretions to loosen up so that we can keep the airway clear of secretions, help mobilize them and loosen them up. Okay, some other things that we might use are like vests that vibrate and vibrate against the chest wall. Sometimes that's effective. Sometimes they use those like little kids, especially if they have a lot of respiratory problems. And sometimes they also use them on like our ALS patients, if we need to, constantly be vibrating that chest wall. Um, Other forms of chest PT, like you can cup your hand and use your hand if you don't have a cupping device. Um, so there's techniques that you can do with that. And also I've taken things like a CPR mask and put a popsicle stick or a tongue depressor on it. And you can actually make a chest cup out of that and use that. And it's soft, but yet firm enough that it promotes that vibration to loosen up those secretions. So, if you're a home care nurse, you come up with a lot of different things in the home because you don't always have equipment, and Medicare and Medicaid isn't always going to provide, the exact equipment that you need all the time and in a timely fashion. A lot of times we're fighting for these patients for stuff. Suctioning, okay, it's going to help you maintain a patent airway and remove not only saliva but secretions, blood, vomit, anything like that, foreign objects, okay. And you can remove it from the oropharynx or the nasopharynx, all right. Um, and so what we have to think about, one, is the patient able to remove the secretions? Two, you also have to think about what kind of orders do you have for suctioning, because nasopharyngeal sometimes requires a physician's order. Also, when you're doing that nasopharyngeal suctioning, the um, tubing is very small. Like, it's a very small hole there. So certain stuff, if it's too viscous, won't go through that nasal pharyngeal tubing. So you kind of have to know, like, what kind of tubing should I use? Where is the Where is the vomitus? Where is the secretions? Where am I trying to suction from? Okay. Um, and, it's different also for trach patients. So, everything is going to be different depending on what's going on with the patient. So, with trach patients, also, you have to remember to suction the mouth. A lot of nurses don't, and they get issues inside their mouth. So, just because they're breathing through the trach doesn't mean that they won't develop certain secretions and stuff in the mouth. Now, the thing about suctioning is that it irritates, the natural mucosa of the respiratory tract. It also deoxygenates the patient, okay, and they can become hypoxic. So you have to pre-oxygenate them, all right, and we do this by giving them oxygen in advance and having them take either a few deep breaths of that oxygen or, just pushing it in with a nasal cannula. Again, that goes back to how's my patient population and developmental age, how compliant are they going to be? Um, and then once you actually perform the suctioning, if it's done correctly, it should relieve the anxiety. There shouldn't be any pain. Okay. And the patient's SATs should look a little better. Okay. Their lungs should sound a little clearer. If it's incorrect, though, we can see an increase in anxiety and pain, and the patient can actually go into respiratory arrest. So when you're suctioning, you want to wear gloves on both hands, a goggle, and a mask, and a gown if necessary. Okay. And also, you're going to monitor the patient's color, heart rate, the color, the amount, and the consistency of the secretions. Any cyanosis, if it occurs, any change in the heart rate, whether it be slow or fast, any sudden bloody secretions, you're going to stop and administer oxygen. All right, and then notify the physician. If the patient develops cyanosis or a change in heart rate or both, that can indicate hypoxemia, and blood can indicate damage to the actual mucosa. So earlier I mentioned about meeting the patient's oxygen needs with medications. All right, that's a dependent nursing action, so we would rely on the physician, physical therapist, and all that because it's probably going to be a team that's going to look at the patient, maybe even infectious disease, depending on what type of respiratory infections that they're getting. And we're going to use these different things to try to create a plan of treatment for the patient. So we also have to think about side effects. All right. So a lot of the drugs will dilate the airway. All right. But in conjunction with that, they have interactions with things like caffeine. All right. So for these patients, you want to make sure that they understand that if they're using bronchodilators, they may want to really go low on the caffeine or avoid it at all if possible. With inhaled medications, okay, we give those when the airway is narrow, and those are bronchodilators, right? These will help liquefy or loosen they can help open up the airway and reduce inflammation. Okay. We also give these mucolytic agents. Okay. Those are going to help liquefy or loosen those thick secretions. And that can also help open up the airway, right? Because if we don't have all these thick secretions in there, then we have room for air to move. They're usually given the bronchodilators and the mucolytics. They can be given either through a nebulizer, a metered dose inhaler, a dry powder. All right, there's several ways we can give them to patients. And then that nebulizer is going to push these fine particles into the deep passages of the respiratory tract. And that will continue until all the medication in that little cup that you have is empty. Okay, so you mix the medication, you put it in there, and you want the patient to take the breathing treatment until it's all gone. If you're giving the MDI, okay, you want to make sure that the patient knows how to use it. So a couple things that patients where they make big mistakes, and that can be not shaking the canister, holding it upside down, inhaling it through the nose, not having it close enough to the mouth. That's why the things that come from the inhaler to your mouth, the little adapters, Okay, those are good because it can help deliver, uh, and the patient doesn't waste. Okay, the medication when they use this adapter between the inhaler and their mouth. So also, they take it into fast. They stop when they feel the cold from that propellant of the inhaler. They stop inhaling it. Sometimes they hold their breath, or they might take 2 sprays in with 1 breath. So those are just some common mistakes that people use with these inhalers. And then, there's a ton of other medications that we use for different purposes. So you definitely want to review table 39.3. All right, that's going to tell you about the different medications, how they work, and what some of those side effects are. All right, so in a nutshell, bronchodilators, those are going to open up the airways. So if we're giving up steroids and, bronchodilators, then we want to open up the airway first, right? And then we're going to shoot that steroid in there. All right, so nebulizers, those have fine particles of liquid, and they go into the deep areas of the respiratory system, all right, or the tract. Meter dose inhalers, those are able to deliver a controlled dose. Remember that there's a lot of issues with these. People not shaking the container, they squirt it and they take it in too fast. They squirt 2 sprays in 1 breath, and you want them to use the adapter with it if possible, because a lot of times they don't put it against their mouth, and so they lose part of the dosage that way. And then also with the inhalers, you have to make sure that they're rinsing the mouth well and all, because it can cause, infections, fungal infections in the mouth. Dry powdered inhalers. So these usually involve something like Spiriva. You get a capsule. It goes in this little disc, and when you open the disc up, this powder shoots into your mouth. Okay, all these medications you have to be careful with caffeine, because they can all cause tachycardia and like nervousness of the system. Okay. How do we deliver oxygen? So oxygen is actually considered a medication, all right? And when you give certain amounts of it, you definitely have to have an order, okay? In situations, though, where there's a clinical emergency, like the patient's O2 sats dropped, or their heart rate increased, or maybe they had a seizure, we don't delay administration of oxygen to the patient. So a lot of times hospitals will have, like in an emergency plan, that you can apply that non-rebreather mask, and 2 liters. So generally, every place I've worked, most policies say you can put 2 liters, or you can put the non-rebreather mask on, and then you're covered. And then eventually you'll end up getting that order covered with a physician's order. But in the state of an emergency, you're going to go ahead and give it to the patient. When you put it on, you want to make sure you tell them why you're putting it on, okay? Because you want to reduce their fear and anxiety. Make sure they don't have any questions. If it's in an emergency, you can do the explanation as you're applying it. Remember, with oxygen, you have to worry about combustion. So what does that mean? It can explode. It can cause fires, okay? Highly combustible. So a lot of things you have to think about. It's not just smoking, all right? You don't want to have any equipment in the room that might generate some sort of spark. So you're checking all your electrical equipment, all your nursing equipment, your IV pumps, all that stuff, to make sure, like, there's no frayed wires or anything that could, cause a spark. And also, you wouldn't want stuff in the room that could fall and cause a spark, because if you did have some kind of leak or whatever, it could cause an explosion. So sometimes you'll see oxygen come from uh, different items, like portable cylinders. Sometimes you'll see it on the wall, and sometimes it's in an O2 concentrator. Okay, and all of them provide oxygen for the patient. You have to think about what's the most economical way. So, like if a patient's moving, around and they have to go to a medical appointment or something, then you might just want to use like a small canister, and maybe an on-demand device so that the small canister will last for a while. If they're going to be at home and they're using it continuously, then they might need an O2 concentrator. And then, masks, different types of masks. So, a Venturi mask, we like to use that for our patients that have COPD and all that because it's going to give them a higher level, a higher concentration of oxygen. Because, with these patients, you can't give them that high flow rate, right? Because it shuts off their ability for their brain to breathe on its own because the brain's not used to that type of stimuli. It's used to a different type of stimuli. So when we give someone with COPD too much oxygen, it can actually shut off their brain and stop it from breathing. Flow rates, okay, are measured in liters per minute. And, these are usually looked at and ordered by the physician, or respiratory makes a recommendation and then the physician orders it. All right, so it doesn't actually reflect the concentration of the oxygen. Remember that. So just because you're giving someone more liters doesn't necessarily mean that they're becoming more oxygenated. And that's why I just talked about that Venturi mask. If you want to make sure you have a more of a concentrated type of oxygen, then you would want to use something like that because you could actually regulate the percentage of oxygen versus airflow. So, you definitely want to look at, those basic safety rules in 39.1, all right, on page 1509 that, talks about oxygen administration and some safety regulations. All right, most places don't require humidification with low flow oxygen. So if it's 4 liters or less by nasal cannula. All right, but because oxygen can dry out those mucous membranes, we do sometimes recommend that there are humidifying devices, especially if the oxygen is delivered at some sort of high flow rate. And normally these devices are filled with either distilled or sterile water, okay? And that's what we're going to use to humidify that oxygen. So you want to make sure that whatever water you use, that it's safe for the patient again. Because water has bacteria and stuff in it, and so you would want to make sure that what you're giving is appropriate for inhalation, number one, and number two, that it's clean. All right, so there's some other things that you can look at in Table 39.2 that talk to you about safe transportation of a patient with a portable oxygen tank, and you would definitely want to take a look at that. All right, so for delivery systems, okay, that's where we're going to start talking about the mask. So we have the nasal catheter, the nasal cannula, the nasopharyngea catheter, transtracheal cath, a simple mask, partial rebreathers, non-rebreathers, venturis, and tents. Each one is used for different things, okay, and has a different function. But you already know, like the nasal cannula, it has those nasal prongs, okay. It's really more of a low flow sort of system. Anything over 4 liters, again, you probably want to use humidified air because it could dry out the mucous membranes, okay? Face masks, these are disposable and reusable, okay? So you want to make sure it fits the patient's face so that oxygen doesn't leak out. It should be comfortable but not tight. And most commonly types are simple face mask, partial rebreather, non-rebreather, and venturi. All right, now that non-rebreather has a bag on it, and you want to inflate that bag because if you don't, the patient's not going to be able to breathe with that mask on. The simple face mask is going to be connected to tubing, humidifier, and a flow meter, just like a nasal cannula. Some of them have vents on the sides that allow that room air to come in at several places. So it dilutes the oxygen, all right, and it also allows carbon dioxide to go out. It's used when we need an increase in oxygen for a short period of time, like less than 12 hours. Okay, and you're giving it usually at a certain amount of liters. It should be fitting close to the face, but not too tight. And you always would want to have this at least 5 liters or more. Okay, never less. So for nasal cannulas, they recommend anywhere from 1 to 6 liters on low flow. And your author actually says you can go up to 15 liters on high flow. For a simple face mask, generally that's for 5 to 8 liters. Partial rebreather, 8 to 11 liters. And a non-rebreather, we usually have it what we call wide open. So that flow is going to be 10 to 15 liters. And again, you want to inflate that bag before you apply it. Okay. The Venturi mask, that's usually used at high flow, 4 to 6 liters. Okay. And then you can set the oxygen concentration for between 24 and 40%. So that's like a little valve that you turn, and it helps you set the mask. The partial rebreather is a simple face mask, but it has a reservoir bag also, and that bag collects some of the patient's exhaled air, all right, while the rest of it goes out through the vents. It's mixed with 100% oxygen for the next inhalation. So the patient rebreathes about 1/3 of the air that they breathe back out through that reservoir bag. So this allows conservation of oxygen, and the patient can inhale room air through those openings of the mask if the oxygen supply is interrupted for some reason. Non-rebreather delivers the highest concentration through a face mask. Okay, and that's to a patient that's breathing spontaneously on their own. It's like the partial rebreather mask in that there's 2 one-way valves that prevent the patient from rebreathing the exhaled air, and the reservoir bag is filled with oxygen that enters the mask on inspiration. So all the exhaled air escapes through the side vents. None is rebreathed back in. And if the bag had a malfunction, it could cause the patient to suffocate or build up carbon dioxide. So remember, I said with this, you always want to make sure that your bag is working properly and inflated. The Venturi mask, that allows the mask to deliver the most precise concentration of oxygen. So you could actually set it for a certain percentage, and that's what's going to go into the lungs. So this is, again, good for these patients like your COPDers. And then in the home setting, they tend to use either liquid oxygen or an oxygen concentrator. Liquid oxygen they like because it's able to be kept in a smaller container and be refilled from a large container that's kept directly in the home. So this way the oxygen company's not coming out every 2 to 3 days to replace the oxygen. So again, things that you want to really be careful about with administration is no open flames in the patient rooms, no smoking. Make sure the equipment is all in good order, that electrical equipment, no frayed lines or anything like that. Don't wear or use synthetic fabrics because they build up static electricity, and you want to avoid oils, right? Why we don't put petroleum jelly on our patient's nose because they could ignite spontaneously from that oxygen. Artificial airways help preserve the airway in a patient who is not able to maintain a patent airway on their own. So we need to communicate effectively with anyone that has an artificial airway. Okay, make sure that the patient with the trach tube, especially that endotrach tube, um, is able to communicate appropriately because they may not be able to speak. All right, communication needs of the patients have to be met. So, what are some ways that you could do that? And a lot of times you can use boards, markers, you can use some sort of communication device, notes. Okay, so what type of communication strategy could you use with the patient? All right, and again, writing boards, letters, vocabulary cards, having that call bell on hand, and then you want to make sure that you reassure the patient to prevent anxiety. Okay, and explain to the patient so that they know what to expect. So for the oral pharyngeal and the nasal pharyngeal, this is a semicircular tube. It's made out of plastic or rubber. They put it into the back of the pharynx through the mouth or nose, okay, and it's put into a patient who is able to breathe spontaneously. It's used to help keep the tongue out of the airway, and it can be used in post-op patients until they return to consciousness. It's also important that we use the airway of correct size, okay? If the size is wrong, then it may not effectively maintain the airway, all right? And if it's too big, it could obstruct the airway. If it's too small, it won't help with the opening of it. Once the patient is able to regain consciousness, then we take that oral pharyngeal airway out. We don't use tape to hold it in place because the patient should be able to expel it spontaneously on their own once they're awake and alert. Endotracheal tubes, these are an airway that's inserted through the nose into the trach. It's inserted with a laryngoscope, okay, and it's used to help administer oxygen through a mechanical ventilator or to suction secretions or maybe to bypass some upper airway obstruction like the tongue or tracheal edema. It's uncomfortable, but it's easy to manipulate with the tongue. All right, oral tracheal insertion is usually the method of choice, but especially in an emergency because it's easier. The larger tube can help make ventilation easier, and the tube is placed through the nasal tracheal root, which is often tolerated better by patients. So it's a little more difficult, and it requires a smaller tube. So sometimes they use what we call a cuffed endotracheal tube because that stops air leakage and it prevents aspiration. And it allows for a more precise control of the oxygen and the ventilation. However, you have to be careful with the cuff pressure because um, it can cause breakdown or tracheal necrosis. Okay, and if a small amount of air leaks, okay, it could cause complications. So that endotracheal tube, once in, the patient won't be able to speak, and that could be scary for the patient, okay? And it also could make them not communicate back with you. Remember, you have to have that alternate method of communication so that you can still establish rapport with them and make sure that they understand everything that's going on. So you want to make sure that you're paying close attention and looking for nonverbal cues in these patients. All right, these patients often need suctioning to remove secretions from the airway. So you would want to tell them about that, and you would want to make sure that you're doing that routine suctioning to make sure that any secretions that accumulate above the cuff also are removed. And that's going to help prevent like pneumonia and other infections in the patient. A trach tube is inserted for a lot of different reasons. It could be used to replace an endotracheal tube, to provide mechanical ventilation, to bypass upper airway obstructions, or to get rid of those tracheobronchial secretions. It's an artificial opening made into the trach, usually at the level of the second or third cartilaginous rings. All right, a curved tube called a trach tube is usually inserted through that opening, and it's done in the operating room or intensive care in sterile conditions, and they use anesthesia. These trachs can be either permanent or temporary, and they're made out of types of plastic, sometimes metal. They come in different sizes and different angles. So, it depends on the condition of the patient, what they're going to actually use there. All right. The metal tubes are a little more cost effective for long-term use. But, again, it's going to really depend on what's going on with the patient. I've actually never seen a metal tube in use, only plastic ones. The trach tube has a few parts, okay? The outer cannula or the main shaft, the inner cannula, and the obturator. The obturator helps guide the outer cannula direction. So when we put that tube, okay, in, it's going to guide that outer cannula. So once we put it in, we have to take that obturator right out because otherwise the patient can't breathe. Many tubes have inner cannulas that may or may not be disposable. So it is nice when the inner cannula is disposable. Usually you can pop them right out in a couple of seconds and just toss them in the garbage and put another one in there. They usually change these like once a shift, depending on how much secretions the patient's building up, how thick it is, those kind of things. Periodic cleaning of that inner cannula prevents airway obstruction and secretions that have accumulated on that tube. Okay, so we want to make sure if the patient's not able to clear those secretions that we're taking a look at that. Again, the trach tubes can be cuffed or cuffless. The cuff seals the opening around the tube to make a tight fit in the trach and prevents leakage of air and aspiration. It also allows for mechanical ventilation. A lot of the new trach cuffs are low pressure and they don't require deflating for short intervals, so we don't have to worry about that necrosis in there. Okay. If the cuff tube is used, you would deflate it before you feed the patient orally, unless they're at high risk for aspiration. If it's left cuffed, the balloon can cause pressure that can go through the trachea and possibly impede the patient's ability to swallow or cause breakdown of the tissue. They also use something called a fenestrated trach. It has a large or several small openings in its outer curve, and it can be cuffed or cuffless. And when the patient's being mechanically ventilated, the inner cannula is in place, and that helps block the small openings. After the patient is disconnected from the ventilator, then that inner cannula can be removed. All right, so it's not recommended for anybody that has a history of aspiration. Always have an emergency trach set at the bedside. Okay, so you're going to have extra parts, right? An extra entire setup, basically. And you should have one of that size and one of the smaller size, okay? Because if you can't get the regular size back in, then you definitely would have one size smaller just so you could try to keep that airway open. So you should have an obturator from the current tube, suction equipment, oxygen, a manual ventilation bag, a spare trach tube of the same size, and a spare trach tube of one size smaller. There's your pictures. So you can see on the left there, you have the obturator, and that's the tube that's going to help you guide it. Then you have a cuffless cannula, an outer tube with a flange, okay? And then on the right, you have the cuffed trach, the inner cannula, and the obturator. So how are you going to administer CPR? Okay, so chest compressions, you're always going to check the pulse. If the victim does not have a pulse, start chest compressions right away. All right, so you want to circulate. All right, they now say from the American Heart Association that the quicker we start those ventilations or those compressions, right, the better off that your patient's going to do. Airway, you want to tilt the head and lift the chin, okay, and check for breathing. All right, so I'm going to make sure that the respiratory tract is open because you can't, put air in if the airway is not open. Breathing, if the victim does not start to breathe spontaneously after the airway is open, give 2 breaths that last 1 second each. And defibrillate. So as soon as the AED arrives, put it on, and it's going to basically tell you what to do. So you're going to start CPR anytime where breathing alone or breathing with a heartbeat are absent. All right, the brain is sensitive to hypoxia, and damage starts to occur in about 4 to 6 minutes. The faster we get that CPR going, the greater the chance of survival. The AED also has contributed to reducing deaths. Okay, remember that's to interrupt VFib. So it's not going to tell you to shock unless your patient's in VFib. It's going to analyze the heart rhythm, and if your patient is in VFib, it's going to advise you to shock. All right, you always want to make sure that you continue to evaluate your patient. That's an ongoing and deliberate part of the nursing process. We're looking at the patient's previous health status. How are they today? Are there things that we can do to get them back to that current level of functioning so that we don't take away their independence?